Well, Dr. Jacquelyn, thank you so much for coming back to Hello Momma.
Thanks for having me.
Yeah, I'm excited to chat with you again, and now with a baby on the way, which is
Yes.
also very exciting. So congratulations on that.
you.
How are you feeling? How has this pregnancy been?
It has been definitely more tiring than the first, and I felt great until like 32 weeks. And I was like, now I could nap 5 times a day. But
Nice.
that's just pregnancy with a toddler.
Yeah, that is, that's
different-
probably exhausting.
It's a different game.
Yeah, totally. We have been toying with the idea of maybe having another one. And I recently made the decision that, you know what, maybe not right now because he's getting a little wild. I can feel those terrible twos creeping up. So I think we're going to hit pause for now and just think about it. And you're still working? Mm-hmm. Good for you. I mean, that's crazy.
Working.
Moms do it all.
We do. Yeah. I was like, still a very busy job. And then I'm also a crazy person opening like a small med spa on the side. And I'm like, why am I doing this to myself? Yes.
Oh my goodness.
I'm like a glutton for punishment.
Where are you opening it?
Up in Plano.
Okay.
Really close to HAB Plano. I'm excited. It's my little side project.
Yeah.
I love aesthetics. Mm-hmm. And we'll obviously talk about like perimenopause, menopause. So,
Yeah.
And I'm also like, I'm at the age where I start needing these things.
Well, yes. I mean, I'll probably have to go visit you once it's open for sure.
That's my fun little side project, but just adding to my plate because I'm crazy, but.
That's awesome though. I mean, that's honestly like probably like a dream job or a dream like business to have because I also love aesthetics, but sometimes it gets a little expensive to, the little Botox here and there, but I need it. I'm getting there too. I can start seeing like certain wrinkles in areas that I didn't think I would get wrinkles. So yeah.
Gravity is just always against us.
It is, unfortunately. Well, let's talk a little bit about a couple of things that I wanted to just kind of learn about. And I know a lot of people might want to understand a little bit more. Perimenopause has been kind of like the word has been thrown around a lot lately.
Yep.
And truthfully, like maybe 4 years ago, I had never heard about perimenopause. And I'm curious why all of a sudden this term has surfaced. Has it been something that was recently discovered, or has it always been around, but now somehow it's being talked about more for whatever reason? So from your point of view, can you tell us a little bit about, like, before we get into what it is, why is it all of a sudden a hot topic?
I mean, I think hormones are having there's good and bad. I think we're talking a lot more about hormones and women's wellness, especially in that perimenopause to menopause period, a lot more online. Mm-hmm. And I think for better or worse, some is like to sell people on supplements and all these other things. But I think more women are clamoring for hormones, especially when they go through either perimenopause or menopause. And I think that is just sparking more conversation. I think in a good way. Yeah. There's obviously some like strange fallout out of it, but I think the generation, let's say my patients that are maybe like mid 60s to 70s and above were kind of scared out of their hormones. There was all these crappy studies that came out in the 90s and 2000s, and like people were doing hormones for a while, and then these studies came out and then they just stopped. And it's really taken a long time to rebuild, providers doing it, getting better hormone options, figuring out better data. And they're like never going to do a big hormone study. But I think the generation now that's like, kind of late 30s to now mid 60s is really clamoring for like, hey, I'm having all these changes. This certainly can't be right. I have to be a functional person, and really talking more about like hormonal changes rather than just being like, oh, it's just something to get through. Good luck.
Yeah. Here's some, pills for hot flashes or whatever.
Yeah. Like the whiny female.
Yeah.
Like,
all we do is whine.
Yeah, sure. It's like, but I mean, it's trying to like meet people with what their needs are and trying to treat those symptoms. Mm-hmm. And just like pregnancy, they're all kind of unique. Yeah. And not everyone's is going to look the exact same, but there's definitely trends that we see when we'll talk about like perimenopause that, on average we see, and that might be able to help people. Okay. Well, before we can start diving in now into perimenopause. So what's the difference between perimenopause and menopause, and what's the differential? So perimenopause is really that like transitional period before actual menopause. So let's talk about like what menopause is. Menopause is actually like what's called a clinical definition. So it's a whole year without a period. Okay. And so like, obviously we can have that with things like PCOS and things like that, but it's like the loss of the, like basically no more eggs are coming out, and that has to be for a whole year. Okay. So there's labs that can kind of help us determine like, are we on that path? And we can go based on people's age and symptoms. Average age of menopause is 51. Obviously, there's some differences, like family history, oddly enough, is important. So if your like mom or and all your aunts went into menopause, let's say at 48, that might be your track. And some people don't go menopause until like 55. But 51 is pretty average. So perimenopause is that transition period before and it's on average 4 years, but it can be up to 10. So I think that's important for like people like myself, like a physician, to know that some people, even in their late 30s, might be going through perimenopause if they're maybe projected to go through actual menopause at 45.
Okay.
So I think it's knowing that those symptoms can exist sometimes earlier than we think. But I would say on average, my clinic, like perimenopause is around mid-40s.
Mid-40s. And what are like some symptoms to start kind of like looking out for?
So it's kind of to dial back and be like, well, what is actually going on in the body at perimenopause, and what is happening is our eggs are essentially like our ovaries are failing. So I kind of equate it to like a car sputtering out of gas. Sometimes it gets too much and then too little. And so we're probably not ovulating properly or getting enough juice every cycle. So with that, we start to see a whole myriad of symptoms. One is going to be our cycles start to be a bit irregular. Sometimes they're normal, sometimes we skip a month, and sometimes we have really short cycles, long cycles with heavy bleeding, short bleeding. So we start to see this like huge variation in cycles. And then, just other changes that come with that. As our ovaries start to fail a little bit, it's going to be like weight gain, mood changes, depression, a little bit more like PMS, PMDD symptoms. So we start to see those more and more. And those are like, they're sometimes really vague, and it's really hard to determine what they are.
Yeah.
Is it anxiety more? Like there's so many different, if I could draw like a Venn diagram, where like all these things like chronic fatigue, sleeplessness, there's other things it could be, but it's like this huge collection of hormonal symptoms that just occur in perimenopause, where you feel like you were cruising and all of a sudden you're like, I do not feel like myself. I am not well.
I wonder if I'm going through perimenopause sometimes, because that's the thing too, because it can be confused with like, maybe you're going through a stressful time in life, and it's like, is this stress or is this actually perimenopause? And it's really, I think just being really good at listening to your body and having a reliable doctor that you can go, or OB that you can go talk to about these things, and just really start having these conversations.
I think it's like, I would say for most patients to like get the most out of it, it's going to take probably a few visits to honestly get right. Like you have to get a whole symptom list, probably check some labs. And those what's so hard about the labs is they can fluctuate so much and change, which we'll probably talk about here in a little bit. But when people are like, well, check my hormones, it's like, well, in our cycle, they vary highly. So it kind of just depends. And none of these things are quite based like your ester. I've seen people dip in and out of menopausal range on their labs because like as I said, sometimes they have enough juice, sometimes too much, and then sometimes too little. But like things we see pretty frequently are going to be like in general lowered progesterone, because just to go back to our normal menstrual cycle, when we ovulate, our corpus luteum, which is like what would feed a pregnancy and keep that lining thicker, that makes progesterone. So we see this progesterone spike around like day 21 of our cycle. And let's say we have a perfect 28-day cycle. When we're not ovulating properly, that progesterone goes, it's pretty low. And that's what causes our regular cycles, right? But so progesterone can be low, and symptoms of that would be like sleeplessness, moodiness, more anxiety. It's kind of like our feel-good, relaxing, like pregnancy hormone.
Yeah.
And then the other thing we'll often see mid-40s for sure is our testosterone starts to kind of poop out on us pretty early, which is an important hormone. I call it the forgotten hormone of menopause because everyone forgets about it. But I'm like, it's really important. Our ovaries make it. But it really is like our feel-good hormones: energy, mood, libido, vibrancy.
Yeah.
So those are the two that I often will look more at. I really don't check, honestly, much progesterone levels because they're going to be like low most of the cycle anyway. But I do definitely hone in on some testosterone levels because I do think there's some benefit for patients in their mid-40s if we're really struggling with some of those symptoms.
That's interesting that you bring up the testosterone. I never would have thought about that. And it makes a lot of sense. Like, I mean, look, after I had my baby, I can definitely feel a huge difference in a lot of things. Like libido is different. My mood is different. Like it can, especially when I'm about to get my cycle. I always had a little bit of PMS symptoms, but now it's like definitely like you can feel them. They're way stronger. I'm on birth control, which has helped, but I went off of it for a period of time just to see. Yeah. And within a month and a half, I was already feeling like these symptoms, but like times 10.
Yeah.
I was like, let me get back on this pill.
Yes.
I don't want to depend on it, but I can definitely see that it's helpful, you know?
Yeah, there's pros and cons. I mean, because I think that you bring up a great point about just when we talk about birth control, because you're not going to have that big progesterone spike and dive, which I think often will help with PMDD or PMS symptoms when you're not getting this huge spike, because it's usually this big spike and then the big dive that makes us feel not amazing. But being on birth control or just perimenopause, menopause, that low testosterone. We talk, more in the TikTok age. So people are talking more about like low libido, feeling just kind of more down on the birth control. And I personally think it's a lot to do with the low testosterone, because it just makes people feel
What can people do to kind of like level those things out?
I mean, definitely there's if we're just using birth control for just birth control and not for like PMDD, switching to something like an IUD that won't affect our ovarian function as much is a great option. And then certainly for my like mid-40s patients, when we're having low T, and I'll even see it in people in their 30s, it's always worth it to check labs if we're having a lot of symptoms. It's going to be like testosterone creams. We do pellets too. I like to kind of do pellets, save pellets for menopause, but I definitely have plenty people in perimenopause that do hormone pellets, and they've got the testosterone in there.
Okay.
But when their testosterone just looks really terrible and they have all these symptoms, like it's worth a try.
Yeah.
I tell people it's not, magic beans. It may not fix the problem, but it's worth trying and following up the labs and seeing what their levels are and do we respond.
Yeah. Well, that's very interesting. And you and I might be talking a little bit more after this.
It's an important hormone that everyone forgets about.
So when do you think someone should actually, I know we've kind of touched on this, but when should someone really start seeking medical intervention for perimenopause? And is it necessary? I guess it is, if you want to manage it.
I think it depends on your symptoms, specifically for perimenopause. I mean, hopefully everyone's going on their annual and we kind of just briefly talk hey, what are your cycles like? Mood symptoms, what's going on? But if we're really struggling and you're I do not feel like myself, something is going on, and we're in our 40s to mid 40s and later, it's a great time to at least see a doctor and see these are my symptoms, and just at least start doing labs. Does it seem to correlate with our cycle at all? What is the menstrual cycle doing? So I think it's going to be based on symptoms. And this is what I was saying a little bit earlier. Some people have really easy perimenopause, barely anything. I feel great. I get people that are 49 and 48 and I feel wonderful. I've never felt better. I was great, good for you. I love that for you. And if you look at their labs, they're probably not amazing, but this person doesn't feel bad.
Yeah. So there's no reason to.
Yeah. I would be I think kind of just go based on symptoms. I don't think you necessarily have to treat low labs just because they're there, as long as their cycles are normal and the patient's feeling overall good. And they're just really kind of monitoring for actual menopause symptoms. But some people just really have a rough road going into perimenopause, and other people just seem to just slide on by.
I had someone on the podcast last week to speak about endometriosis. And I wonder, someone who suffers from endometriosis and it's so painful, they might, I'm assuming, you can correct me if I'm wrong, but some of the symptoms of perimenopause could be masked under similar symptoms of endometriosis. Or do you think someone that goes through that, could there be maybe some roadblocks there when it comes to identifying the difference between the two?
I guess it would depend on their symptoms. And, in some ways, menopause is a light at the end of the tunnel for some people with endometriosis, at least no cycles.
Yeah.
But with those things leading up to it, when our cycles become heavier and more disordered, when you start having all these really painful, heavy periods, I think that could make it worse. Yeah. I'm not sure that I necessarily see my patients with endometriosis maybe struggle more. That's a great question that I'm I don't know. If I think about my normal clinic, I'm not sure if I would say they get more cycle issues and we end up doing things like ablation, hysterectomy at that time, because they already kind of have such disordered bleeding and their endometrium and all that stuff is abnormal. And this kind of just finally pushes us over the edge where people are I just can't take this anymore. Yeah. And then we do other interventions.
I was also, this was a while ago, I was listening to this podcast and it was, and I can't remember her name, but you probably, she's very vocal about perimenopause and she's very popular on TikTok.
Mary Claire Haber, Dr. Mary
Probably.
Claire Haber, yeah. But I think she sparked a great movement.
Yes. So she was basically the one that was
yes.
She said on a podcast when she went to school or medical, she was menopause was just a quick course.
Right.
And that was it. And majority of OBs are men, so they don't experience this. So there was never kind of research done because they don't feel it. It's not their fault. It's just, and then a woman would come and say like, oh, I'm having these symptoms. They're like, oh, totally normal. It's normal menopause. Have a glass of wine. Yeah.
Thanks for that advice. I'm glad for my $60 copay for you to tell me to have a glass of wine.
So I guess, so she did spark a lot of movement. And
I think she's a huge person to thank for like the big conversations that are happening. I see a lot of posts from her or like on her comments about people running into roadblocks and being just a voice for like, yes, I'm not crazy. I'm having these symptoms. So like, I don't agree with her exactly on everything, but I think she has sparked a really great conversation. And with that has promoted other people that have a ton of great things to say about menopause. And we are finally talking about it in like, not a scary way. Cause as I talked earlier, I think people were scared off their hormones by these crappy studies from the 90s and 2000s that are like, estrogen pills, fake progesterones called progestins. And we don't even do really that anymore. I don't have anyone on those.
Okay.
So it's like, it's come a long way, but we're a little stuck because they're just never going to do a big study again. So we have to go based on what have I been doing for the last 10 years? And it's like all the OBGYN brains get together and be like, okay, what is everyone finding success in?
Yeah.
So I know they're kind of clamoring now for better FDA approval for, like, for example, testosterone. And to get rid of this FDA warning on estrogen cream about its like cancer risk, because this happens to me all the time. I prescribe it and then my patient opens that thing and they're like, oh, I heard this causes cancer. I didn't use it. And I'm like, well, so it's trying to like undo some of those.
Yeah. And I think that's probably, someone who, again, is struggling, finding the right doctor to be able to get diagnosed is a challenge.
It is. And to her point, like I got like maybe one day of training. And I think to be, and I like always love when people come in for hormones. I'm like, yes, I actually really love talking about this. And not everyone has that sort of reaction when they're like, oh, this person wants to talk about their hormones. So there's is it National Menopause Society? There's a Menopause Society, and then you can look up doctors. But like for example, I'm not even on it. And I'm like, find myself very pro hormone. So maybe I should be. But, I think a lot of it is kind of referrals from friends that are on it. I hate to say that's the best way, but I get a lot of people from mom groups or things like that. And they say, oh, you can go to Dr. Means. She actually wants to listen and dive into it. So a little bit's that way, but I do wish there was a better training, but better list of people that were kind of more interested in those things. When you go to an OBGYN, I mean, we do so much. It's such a wide variety. And I think we all have our little niches that we like. So it is a little bit of a challenge to find someone that you think is going to listen to you, because you don't want to waste your time and you don't want to go away frustrated, be like, well, that doctor didn't listen to me at all.
I know. Yeah. Or they'll just be like, oh, just go on antidepressants or and it's not always the solution.
Yes. And that's like a lot of primary care doctors' solution too. And I get, but like it's not invalid. I mean, there's definitely some anxiety, depression symptoms. And I've definitely had people on, I'm like, well, let's try the hormones. But like, honestly, you're giving me a lot of anxiety, depression symptoms too, if we're not much better.
Right.
Let's, we need to treat that, but at least we can try some hormones first. And if we still aren't fixing the problem or it's not 100%, we can talk about those other options. But I think it's like unlearning all these many years of school. I mean, I still get tons of primary cares. Why are you on that? This is causing cancer. And I'm like, well, where's the data?
Yeah.
That's true. And then pharmacists, when people pick them up.
Really?
Yes. I'm like, can you not?
Wow. Yeah, dude.
Yeah, they're like, wow, this dose is really high. And I'm like, no, it's normal dose.
Oh, wow.
So I think it's getting better for, again, like Dr. Mary Claire Haber and all her people and everyone talking more about these things. But it's like, going to take a while to get rid of some stigma and just some bad lessons learned. Yeah. And just reviewing the data. Again, there never is going to be a study apparently. So
and why is there not going to be a study?
I guess it's not worth the money to like NIH. It was such a huge study. And so that's just what I hear in the community, that's probably never going to happen.
That's very unfortunate.
Maybe some billionaire that's listening wants to find a study.
Please. I mean, it's just like the common thread with women's health in general.
Sure.
Like Viagra, of course, let's invest billions of dollars in research and making sure that this is available. But when it comes to like our health and our well-being, it's just kind of like a constant struggle.
Right.
When it comes with everything. Like, again, I had this guest about endometriosis. It's even getting diagnosed for that is a struggle.
Yes.
And, being heard, like she her whole life she had symptoms and she had no idea what it was until someone
Right.
came to her and took the time
Yeah.
to listen.
I had a endometriosis expert, Dr. Stuparich, on. We did an Instagram live. She's an endometriosis surgeon. We just talked a lot, but my main thing that I found in all my research, I'm like, it's such a not well understood disease, and it's just like there's nowhere to go but up and improvement. But
Yeah.
I think we're finally maybe getting better at like listening to patients' concerns, but like there is so much more research to be done about what actually causes it. So yeah, Dr. Mary Clay Harriver talks a lot about how like women are not just mini men. And those are the studies where it's like, well, we're very different.
Yeah.
And, you know, there's, as we talked about earlier, there's big clamoring in the FDA for like, let's say a female dose appropriate for testosterone. There's so many male options. You know, you get androgen and all like testosterone injections, but there's not for women. So we're left a little bit
To our own device.
yeah, or just like kind of figuring out on your own or like with other companies being like, well, I kind of feel like this works. But there's really no standardization, which I hope we'll kind of get to a place where that's going to be the thing in the next like 10, 20 years.
Yeah. You also focus a lot on fertility at your clinic. So what are like I guess, how do you identify or what's the process? Like if someone is struggling to get pregnant, what's kind of like the first thing that you kind of start digging into?
Yeah, I mean, the biggest...
I'm sure there's like a lot.
There's a lot, yes. Yeah. And I'm definitely not a like REI or fertility specialist, but a lot of people come to me at least as the first entry point, and then we kind of do some workup and then go from there. The biggest thing that I often will want to know about is like, what are the cycles like? Are they normal? Are they regular? Are we skipping around? Are they long? Are they really painful? To me, that gives me the most clue about what's potentially going on. Because we talk about fertility, there's lots of things that impact fertility, but the biggest one that I'll see people coming to me for is going to be like something like PCOS or polycystic ovarian syndrome, where we're just not ovulating. And that's, of course, really important to get pregnant. We have to ovulate.
Yeah.
So either we're not ovulating well, we're not ovulating every cycle, or just not at all. So kind of getting a better history from patients. And then I do run a panel of labs, get them in for ultrasound, check out the ovaries, see if there's anything else. But hormones are obviously a huge part of that too. Yeah. I'm an affiliate for Anito, which is like a smart ovulation kit. And I love it. If people just want to know about their hormones, it's nice because it tracks your cycle for like 2 weeks and tells you 4 different hormones, which is like very different than any other ovulation kit. But it's great for PCOS.
Okay.
Because sometimes people have all these normal cycles, but when you actually do the kit, you're like, your hormones are not telling me that you're ovulating. We're obviously having some problems, either that we're not getting that what's called an LH spike, or the estrogen's not spiking either, or we're not getting a really nice progesterone rise after that happens. So it's nice to just have more data, I think, and then we can make better educated decisions. Because honestly, like PCOS with ovulation issues is one of the easier things to treat fertility-wise because there's good just pill medications for it. Okay. So I'm actually kind of like sometimes excited when we at least have that. I'm like, hey, this could be like potentially easily treatable. Let's at least try it. Yeah. And if that doesn't work, then of course we go on to our fertility specialist.
What are like what are the pills for PCOS? Because I think we touched on this last time we spoke. I was diagnosed with PCOS a long time ago. And at the time it was a male OB. Right. And the solution was, going on birth control.
Sure.
And so I did, and I was like, okay. And the message was like, you're going to have a lot of trouble having kids. Okay. And I just kind of like went about my day. But now, I had no idea what it was. I had to do like my own research. And even then I was like, well, I guess I have some sort of syndrome and I just have to manage it with birth control. Right. But clearly there's a lot more research. It's been talked about a lot more. So what is like the pill that you give that you're like, oh, it's so easy now? Because before like PCOS was like, oh, this is terrible. Right. And this is like uncurable. Like, I don't even know is there a cure for it? Or is it like, is something that you cure?
Right. It would be nice if you can manage it. I kind of equate it to diabetes or thyroid disease where I'm like, we can manage it and sometimes don't need to be on meds. But Femara or letrozole is common. Letrozole is actually like a breast cancer drug. So it tricks your body into thinking its estrogen's low. So you take it at the first part of your cycle, and then we then super produce estrogen, and that is enough to get people to ovulate usually. And it works great. Yeah. It does work. But that's, definitely easier than doing like injections and other kind of things. But I will see a lot of times people being on both Femara and then also progesterone, which is called like luteal support in their second phase of their cycle for PCOS. But PCOS, just to go back to like what your, male OBGYN said back in the day. PCOS is so interesting. Everyone's is so different. I have some people have no problem at all. Like a lot of my patients have PCOS and get pregnant lickety split because they're ovulating most of the time, maybe just not all the time. So it kind of depends on how severe it is. And that's where I go back to like, what are the menstrual cycles doing? If this person is not having a period for 6 months, like we're probably going to see some help. But if we're like having fairly normal cycles, things might still be going pretty well.
Yeah. It's interesting that you say that because I remember when I got diagnosed, I never really had issues with my cycle. My cycle has always been pretty consistent, like forever. I've never had terrible periods. Honestly, everything has been pretty normal. And the reason why I went to him is because at the time I was dating someone and every time we would have sex, it would hurt. And it would hurt specifically like in that area. So he's like, oh, well, let's see.
Maybe like an ultrasound.
They did an ultrasound and that's when they found it.
Yeah.
But I never again got, I never checked on it again. Yeah. And I got pregnant and it was a surprise, but I pretty easily.
Yeah. You're like, well, I must be fertile.
Yeah, I guess I am. So yeah, I think it's just, sometimes you can just miss it without even knowing because again, my cycles were always pretty normal. Maybe with like some variation, 2-3 days, but.
I see that too. And I can't quite understand, like, if I really think about it, why exactly that's happening. Like where I feel like if you're not kind of looking for PCOS in a lot of ways, you're missing a lot because people can have those like normal cycles. Yeah. So it's like, well, maybe you had some normal cycles where you weren't ovulating, but that like your body was still bleeding every 28 days. But I don't know, there's stuff called Rotterdam criteria where like, you have to look at sonogram, but also labs and also the patient's complaints and irregular cycles actually has to be part of it. But I don't know. I feel like there needs to be a different diagnostic criteria too. It's we don't quite fit in that perfect box. It's definitely a spectrum. That's all. That's my.
Isn't that women's health though? It's like, it's all a spectrum.
PCOS is one of the really interesting things to me too. I'm like, wow, we really don't, and we're seeing more and more of it and we don't really know why. Yeah. Is it stress? Is it our diet? Who knows? But that is another area that I would love to see research more. Yeah.
Well, now that you say diet, like that was another thing too that he mentioned. He's like, well, you're a little overweight. I don't even know how much I was weighing at the time. He's like, so a healthy diet and exercise will help. So he's like, it's manageable. Like, and I think he mentioned like, it's just like diabetes. You just have to manage it. Yeah. I really never paid attention to it. I was like, okay, I mean, I can live with this. But yeah, I do appreciate there's more conversations going on around it, more research, but it's just, he feels like it's never enough.
Yeah. I mean, I'll get people all the time too, where we do a sauna for a different reason. For yours was like pain with sex, and we happen to find this, and I'll find that too. And I'm like, oh, that's kind of interesting. I wouldn't have thought that. And the patient's shocked as well. And then we do more labs, but I have tons of people that are in gray area too, where I'm like, our labs didn't really show you're this, you're that. I just say we put that card in our back pocket. Maybe we have it. Then we kind of visit another day. But there's definitely a whole slew of symptoms. And I think good and bad that the internet exists. I think lots of people are told online. They're like, I have this. And like, okay, well, but also it's always someone trying to sell a supplement or their program. And you're like, this is.
You got to be really careful with
preying on women's vulnerabilities, which is kind of obnoxious. But at least they maybe come to me and we figure things out together.
Yeah, social media it can be a wonderful thing and it can be the most dangerous thing. And I kind of touched on this in the last episode, but especially during my pregnancy, I would rely on Reddit a lot. I love Reddit. I'm like, okay, because I feel like Reddit is, it's pretty reliable. And like when people are sharing their experiences, obviously you have to be careful. You can go down some rabbit holes. Yeah. Same thing with TikTok, but it's so important for people that are sharing this information to be careful on what they're sharing and even the people watching, because you can get sucked into something that is not good for you.
Fear-based content always does better than anything else. So they're trying to make you very nervous and scared. But yeah, the whole pregnancy thing, I'm like, I even get out, I'm pregnant. It's like telling me all these things and it's all these channels. It's like, your doctor wants to do this to you. And you're like, okay, come on. Yeah. But I just have to say like, not interested. Yeah. Ugh.
Well, let's talk a little bit about your pregnancy. I know we kind of touched on it. So you said that it's been a little different from one to the other. What have been like the biggest differences? Like you're tired more?
Definitely just more exhausted. I mean, you're chasing around a toddler. You don't get to nap when you want to. But I overall feeling really good. I had gestational diabetes with my last, and then I got it early this time. I failed. We had to do an early 1 hour. I'm sure you remember that sugar drink.
Oh my God. Yeah.
Mirrors. Yeah. So I did an early 1 hour, and I was like, F it. I'm not doing a 3 hour. Just give me my glucose monitor. I'm just
3 hour one was brutal.
Brutal.
Yeah.
Yeah. I failed mine big. My fasting was fine, but then I went up to like 200s and then I went down to like 60 on my 3 hours. So it was like all over the place, but I managed with diet the first one and still doing fine on diet, but it's like, it just sucks not being able to eat what you want.
Yeah.
But it makes me look skinny. It's like amazing how bad sugar is for you. You're like, darn it, that doesn't
I know.
track that.
I was probably the skinniest I've ever been during my pregnancy. Like I was just belly like you. Like it was, but I was skinny. I'm like, oh, it's all the wine that I drink.
Yeah, wine and just all this. I mean, it's kind of amazing when you make choices. You're like, oh, I'm eating more salads.
Yep.
Darn if that doesn't work.
I know.
But I've learned a ton about just insulin resistance and eating in general, which I took from my first pregnancy and continued on. But now I think I'm going to have even more kind of like life lessons. I just pray I don't get actual diabetes. That would be kind of sad for me long term to not eat what I want. But overall, I'm going fine.
Yeah.
We definitely can talk about postpartum and hormones.
Yes.
Because I get these questions all the time in clinic.
Let's do it.
Well, because postpartum is essentially menopause.
Yeah. Okay.
And I think people kind of don't.
Yeah,
I know. Right? It was like, it's all the very similar symptoms, but it's from a different thing, which is going to be prolactin, which makes us produce breast milk, but that shuts down our hormones in our pituitary, or FSH, LH, and so we don't have any estrogen, progesterone, or testosterone. So, but we get all that's why people get the night sweats, hot flashes, vaginal dryness, low libido. I mean, low libido is like a multifactorial thing postpartum, but a lot of those symptoms are going to be very similar to what we experience menopause.
And how long can these symptoms last? Because I'll tell you, I've been, a year and a half and I still feel a lot of these things, Right. And so some people are like, oh, it's just 6 months, or, your body takes 2 years. So it's, what do you think? Or
there's, I think, not enough official research to say. I see those things online too, where it's like, oh, it takes your body X amount to heal. It's probably like 2 years to feel hormonally balanced. It probably does take about a year or two to really feel hormonally balanced. But I think there's so much also at play. It's like loss of identity, loss of self, sleeplessness. It's so much other things in addition to the hormones. And there's all that research that like pregnancy changes our brain function. How does that play into it? But there's definitely like hormonal aspects at play, and then also just just the life changes that smack you in the face when you become a mom.
You know who I think needs to hear about this more is men.
Sure, yes.
They need to understand
I was
that
reading
it's not normal. Like our body goes through so much after, not only during.
Yes. It's like, it's not just because the baby's out, like, oh, she's back to normal.
Yeah, no.
It was like, no.
First of all, your organs have to like reorganize themselves. Yes. And then all these, like, you're depleted from everything, vitamins and all these things that your body needs. And it just takes, and you don't even know what to do because everybody has a different opinion, or, you try to do the things that you feel are right, like exercise, eating right. I'm going to therapy, like I do all these things, but it's like it's a constant battle.
There needs to be a better postpartum. I mean, it's everywhere online, right? It just needs to be better managed, better support for women, just for all these change. I mean, like, you're just non-functional. And I think people that really do well postpartum have a really good social network, support great husband, but also like maybe they have a really involved mom, mother-in-law, maybe their job is more flexible. We don't have those things. I just see those things really break down. Yeah. And it's really hard. And those women are really scarred for a long time because they just thought like postpartum, which is so awful. It was such a dark period of life, which is so sad that
it is.
We aren't helping women, in that early stages of motherhood, and that just leaves these like scars for them. Yeah. And they're just like, I'm not getting pregnant again, or not for a while. They're like, I can't go back to that. Yeah. It's terrible. So I'd like to see that improve. But I get plenty of people being like, well, why is my libido so low? I'm like, well, it's a whole bunch of reasons. Yeah. I was like, you're tired. You've been left open. Like, you're touched out, but also your testosterone sucks too. Yeah. So like the minute I stopped breastfeeding, like the next week I was like, oh, there's my libido again.
Oh, really?
It was fun. I was like, oh, it was really crazy how quickly my body was like, oh,
it just bounced back.
I just felt like back to normal. But it's just, that to me was, I'm like, maybe not everyone's is going to be so drastic, but I was like, oh, I feel like a whole new person. For me, breastfeeding made me gain more weight because everyone talks about, oh, it's such a weight loss thing. You're burning so many calories. No, I was like definitely, I don't know, just those low hormones for me.
Yeah.
Put on weight. So everyone responds differently.
Yeah. I gained weight after pregnancy. Like that's when I gained the most weight, especially after I had my first cycle. I could just feel like my body kind of like blowing up. Like within, I think I got my first cycle, I want to say 6 weeks after I had the baby.
Yeah.
It was pretty quick. And then after that, like I gained from my pre-pregnancy weight. Basically, I gained like 40 pounds after I had him.
Yeah.
I was almost at 200 pounds. And so I had to go on a GLP-1 to help.
God bless GLP-1.
Yeah, seriously. It was a lifesaver.
Yeah.
And obviously I'm doing a lot of exercise now and getting back into my normal routine. But it's just, those are things that people don't know. People think that once you have the baby, that's when you start losing weight. No, for a lot of people, it's the opposite, whether you're breastfeeding. I don't know why I gained weight. Honestly, I just think my hormones were out of whack.
Sure.
And I could just feel different. And I started buying like double XL pants. And I was like, okay, I need to do something about this. It's just,
Well, I mean, thyroid, a hormone that we haven't talked about yet, also just does crazy things postpartum as well. And it can be up and down, you know, and is it stress that's causing that? It's hormonal imbalance. So thyroid's definitely a huge player. But again, you know, like, we're just not eating great. When we're lack of sleep, our body is like constant cortisol mode, fight or flight. So all those things just collude to make us to gain weight and do all these things. But some people are really skinny. I know.
I mean,
like
bless you. Yeah. I have a friend who just had a baby and she's back to like her pre-baby weight. And I'm like, and she's titiny. I'm like, God damn you.
Yeah.
Like, seriously.
So it just really depends on the person and our metabolism. But like, you know, everyone's menopause for those is very different too. Some women really will, I know, I'm like, this doesn't bode well for me in menopause. I'm going to be enormous if I was big with breastfeeding. But I was like, you know, some people really, their weight's going to go up so much with that. And other people really not too much, you know. So there's a lot of individual differences. And that's what's always challenging about hormone management is everyone's kind of unique-ish.
Yeah.
But it's all, you know, when you try a therapy, you have to start somewhere. Yeah. But I always know like, we'll see kind of how it goes. Everyone's kind of unique and different on what their dose is and what actually hormones they need. Yeah.
Well, I have my aunt and my mom going through menopause. My aunt, though, I mean, she's been going through it for the past, I guess, 5 years because she's always hot. So, like she can't be in a hot setting. She's always having a fan with her. My mom is too. And I think it was through this doctor that we were just talking about. I'm bad with names. Again,
Mary Claire Haber.
Yes, her.
Yes.
That's also like not normal. Like you shouldn't be having hot flashes for so long. I mean, of course you don't have to struggle. So it's like, how can we help these women?
I think with our generation, we're going to be more on the offset of like the minute you start feeling them, you're like, I got to get to my doctor. Yeah. And at least I'm plugged in and they're going to do something and manage them. But I think I see this a lot in my clinic where people think they have to like bludgeon through menopause and it's just something to get through.
Yeah.
And, you know, those hormones are never coming back. We were not meant to live to 100. So now we're living like half of our life without hormones. And I think people really need to think strongly if hormone replacement is something they should consider, not just for management of like hot flashes and dryness, which is all we're really taught in med school. It's like, only give those to people who are really struggling. Yeah. But I kind of think about it more now from an area of just wellness, where it's like, actually, there's a ton of data to show that estrogen is so important in every cell in our body as women. It's important in everything, but our bones, our heart health, there's studies about just how critical estrogen is on those pathways. So I think about estrogen and progesterone and testosterone replacement more for like wellness and longevity. And it's just kind of flipping the script on it. Yeah. Rather than like, oh, it's just to kind of help me. And I only need it if I'm really struggling. Because I think it's just as women, we're like, oh, it's going to get better. It's going to get better. And then suddenly we just have to push 2 years have passed and we're fanning ourselves every day. Like,
well, seriously, like I swear to God, I feel like my aunt has been going through this for years. And so has my mom too. And I'm just like, you know, when I started hearing about all this, I was like, well, maybe we should consider. The other thing I've been hearing a little bit about HRT, hormone replacement therapy for those who don't know. the thing about it is you have to go to specific doctors I mean, you can't, it's not always accessible is what my perception is. And so I think that also makes it harder. And people have this idea, including myself, sometimes that when it's like so specialized and it's not, insurance doesn't cover it and you have to like pay a lot of out of pocket. It's like, well, is this really something that's reliable? Like, why isn't insurance covering it? Well, you know what I mean? So it's kind of like, I think there's this old school mentality of like, if it's not covered by insurance, then it's not
needed.
Yeah.
Which is frustrating for sure. And like to speak on a few things on that. One, again, we talked about like some doctors have their favorite niches. Some people just want to do OB and young people. And once you're 45 and older, you know, I'll do your PAP and that's it. I do think, you know, there are hormone specialists, but then I also think some of those things get very weird and it's like too much. It's too much on the supplements. And I'm like, you know, maybe somewhere in between is fine where you don't have to be so intensely crazy here, but also we can not blow it off either. But a lot of hormone replacement, it's at least just estrogen and progesterone are going to be covered by insurance. Okay. So that should hopefully allay some fears. And so are those visits. I mean, we just code under menopause, hot flashes, decreased libido, what have you. Testosterone is always going to be generally out of pocket. It's not terrible. Like a tube of cream costs like $50 a month.
Okay, not too bad.
Not bad, but of course, like look at probably men's testosterone, probably like $3. So you have to pay a bit more. Pellets aren't covered by insurance. Pellets are like, how can I describe pellet? I call it like the Cadillac of hormones. It's this little like dissolvable grain of rice. Essentially, it's in your hip fat.
Okay.
And there's definitely a convenience factor. You're not having to apply these creams, patches. It lasts for longer. And some people like to be at the little bit higher levels that the pellets provide. So it's not for everyone.
Yeah.
When people only have pellets, I find that a little strange. They have to have more things in their arsenal.
Can you explain a little bit the difference between the cream and the pellets?
Sure, yeah.
So like, where do you put the cream?
The cream is usually on your thigh. But what's not fun is like you get a little more hair growth there. Okay. That's why I say like there, because it's a big surface area.
Got it.
We do get a little hairy there sometimes. The cream is great. It's usually what I will start people on because I dip our toe in the hormone waters. Because once I put a pellet in, I can't take it out if we didn't like how we responded or things like that. So I do like that the cream is easily adjusted. It's like a deodorant stick essentially. So it's like these clicks, like an old deodorant stick, and then that's what you click on. So you can kind of adjust your dose a little bit. It's just to me highly variable how much people absorb. Like sometimes I see people do not absorb at all and their level just barely changed on it. And other people I see like in the 200s. I'm like, whoa, really? And then we try to adjust, but that's the one negative I find about the cream. And then it's a little bit annoying to apply. People forget. So the pellet, I usually say we graduate up to it, is going to have more steady Eddie levels of testosterone, but you don't have to apply the cream every day. Right. And you kind of know what you're getting. That's like once you've been on it and you're like, I know that I feel good on this. Testosterone, you know, it's got pros and cons. It's got side effects, unfortunately, some hair growth, acne. When people start getting a lot of thinning hair, I'm like, we're on too much.
Okay.
But I mean, some people feel so good on it. They're like, I don't care. You know?
And is it the same?
Balance.
Is it the same for men? Like when they get testosterone,
they get a ton more, right? Because men just need so much testosterone. Right. We're like, again, not many men, but we need a lot less compared to them. Yeah. But I think we just forget that like our ovaries did make testosterone, and maybe we need that too. And there's also like a lot of good data about testosterone and what's called androgens, essentially like their cousins. That is very important for like vaginal vulvar health. Oddly enough, you wouldn't think that has anything to do with it. You would think estrogen only down here. But there's a lot of good data or just like experience in clinic that putting people on androgens or even some testosterone helps with symptoms. So genitourinary symptoms of menopause. Who knew? Yeah, who knew? So I always learn so much with you. We always cover so many things. I'm constantly always learning too. Yeah. I was like, I think if you're going to do hormones and be a hormone provider, you have to be a lifelong learner. Yeah. And you have to really listen to your patients and see like trends. You're like, that worked for them. And I hear this from this. Like you have to, because there's not great studies or data, you really have to be like finding the right sources and hearing, oh, that worked for that doctor. Great. Tell me more. Well, before we wrap up, is there anything that we didn't cover that you wanted us to cover? Look at your notes. Yes. I was like, I have tons. I do. Yeah. We still have to give a shout out to Dr. Mary Claire Haber for at least putting this on the map. I think, you know, I get a lot of people coming in being like, oh, I need to check my hormones. It's like, what does that mean? Yes. You know, Tell me what's going on. I think that's where the internet gets weird because people are checking people's hormones online, and your hormones really matter if you're premenopausal, like where you're at in your cycle. Or like, what does this mean? What is this? They do this whole panel and they want you to sell them a supplement.
Yeah.
It's just kind of like predatory. So I was like, there's good and bad, because everyone wants to check their hormones if they don't feel good. But I'm like, well, it's kind of like always multifactorial.
Yeah.
I think we definitely touched on like perimenopause really well. Menopause, I think we touched on most of it. I just think, the symptoms are so like a high variety. And I think we touched on, it's not just hot flashes and dryness. Like Dr. Mary Claire Harry was talking more about frozen shoulder. And the more like I heard her talk about that, I'm like, oh, you're right. Like people are having more arthritis symptoms because estrogen like lubricates the joints and bones. That's so interesting.
That's interesting. Yeah.
So it's like once you kind of find out like what the whole myriad of symptoms of menopause could be, you're like, oh, that's so good. Like I am having all these.
Yeah. Okay. Yeah.
So getting a better questionnaire, I think, for patients is helpful too. If you're just screening for like hot flashes, menopause, you might be missing some.
Yeah.
But as I said earlier, like I'm really kind of changing my tune about hormones. And I honestly do give out like Dr. Mary Claire Haver's like book and just her, all the things. I'm like, do your research. I don't want you to feel like I'm pushing this on you.
Right.
But like, let's check your labs. We can come back and have a real talk. Because I don't want people, you kind of miss your opportunity a little bit to have those better health benefits if you're trying to not do hormones until like your 60s or so. Because some people feel okay in their 50s, but once our ovaries really stop working, we suddenly have like all this mental fog. We feel like just so bad. And it's trying to prevent that huge slump, but also when you do start hormones in the first 15 years after menopause, you get the better health effects.
Yeah.
And there's like ACOG, who's our governing body. They talk about stopping it at 65. It's kind of like an arbitrary number.
Okay.
What I found, I mean, some people, I really don't find that my patients want to stop. They're kind of told based on that number that they need to stop.
Yeah.
So I think it's definitely an individual decision on who should, who's a good candidate, continue or not. Because I have lots of people still in their 70s on it.
Yeah.
Like, you're going to pry these out of my cold, dead hands. Because they feel so good. But it's like, what's the point of making this person miserable if we're still hot flashing? People still hot flash at 72.
Yeah.
Isn't that crazy?
I know.
You think it'd just give it a break. But it doesn't.
Their bodies are just like, relentless.
It's a definite challenge, but there's things like where people cannot be candidates for estrogen or progesterone, for breast cancer being a huge one. There's other things we can do, but that is really frustrating. Yeah. That we have to kind of pivot and do something different. And then people like heart disease, stroke history, blood clots, the estrogen is going to be contraindicated in those. So we've come up with some better solutions, but they don't really they're helping the hot flashes and other symptoms, so they're not really helping some of those other bone, heart benefits and things like that. So I wish we had better targeted estrogen options someday. Yeah.
What can someone, for example, like my mom, she's in her early 60s. What can she do? Maybe more, I don't know, what kind of exercise, what kind of foods to strengthen her bones a little bit and just maybe help alleviate if we're not going to go the hormone therapy route. Sure. What are other options that?
Well, definitely vitamin D, huge for bone health. Okay. And vitamins, actually A, D, and K, probably huge. Okay. Calcium used to be the big thing, and now we think maybe too much calcium is not great for our heart. Okay. So kind of in moderate amounts, but vitamin D being the big one. And then for sure resistance, strength training, walking with a weighted vest.
Okay. Well, I started walking with a weighted vest.
Know, that's the new thing.
I know. I saw a couple moms do it. I'm like, I'm going to do it too.
I don't know about summer in Dallas with a weighted vest, but
early mornings walks with the weighted vest
maybe
are bearable.
Maybe ice pack.
Yeah.
Places they can yeah. But yeah, weighted vests are huge. And there's balance training. Okay. And obviously just following the bone density. And then, just for heart disease, which is going to be the number one killer of women post-menopause, is to really eat, really well, get enough fiber, proteins. Our protein needs go up so much post-menopause. We can start to get muscle atrophy. So making sure we get enough protein. And I kind of hope, I think I see this more happening, really true, menopause dietitians that really focus on that area. Because it's a very different way of eating. Just like pregnancy, it's a very different way to eat. Again, the protein and all that stuff being so important.
Well, that's really good to know. Really, I'm probably going to start doing it myself just to prepare, you know.
We're in
leading
the
up to-
age where it's important. You
Yeah.
are setting the groundwork for how menopause is going to go. Like our 40s is actually so important to put on muscle.
Yeah.
I should tell myself that too. I'm like, I gotta get back
I
to the
know.
gym.
I need to the place that I'm going for exercise, like they focus a lot on strength. So I'm definitely doing a little more of that. And I have the weighted vest because, you know, I'm going to be 39 this year. I'm not getting any younger. And we just have to start thinking about these things and taking care of ourselves to set us up for success so that we don't have to go through what our parents.
You don't want to be like losing height every year, just like our cute little grandmas used to. But it's like, no, we're going to be a different generation. We're going to be stronger. But yeah, it's because we're living so long.
Yeah.
If we have to make it to 100,
seriously,
we have to put some groundwork in now.
Yeah. Speaking of the weighted vest and posture, like I have definitely felt like it makes me like, you know, it makes me think about my posture more for sure.
Well, that's good too. Yes, we can keep our spine straight.
Yeah, absolutely.
Very cool.
Well, Dr. Means, this was amazing as usual. Thank you so much for sharing your knowledge and for coming back on the podcast. Just as a reminder for those people that maybe didn't listen to you the first time, where can they find you?
You can find me on Instagram at The Honest OBGYN, and then I'm a private practice owner up in Plano, Texas at Plano Women's Healthcare.
And speaking of private practice, when does your med spa open?
It's hopefully by like end of the month, early August. It's called Renew Boutique Med Spa.
Oh.
I have an Instagram page. It has no images, but it's going to.
Okay.
So I have like CO2 laser, radio frequency mic. I'm doing the big stuff.
Yeah, nice.
I mean, obviously injectables too, but I like a surgeon.
Yeah. Well, awesome. I'll definitely be visiting, and I'm sure other people will too. But thank you again for coming on the podcast. This was amazing.
Thanks for having me.
Of course. All right. Thanks, guys. Bye.
Bye.